I'm thankful that I've been given the opportunity to share the experiences with emergency protocols and emergency letters for patients with glycogen storage diseases and fatty acid oxidation disorders. I'm presenting on behalf of many colleagues and patient representatives who have been collaborating in the last decade. I would like to share with you that this is more than a project, and ideally it should be a sustainable process. My name is Derks. I'm working as a metabolic pediatrician at the UMCG in Groningen in the Netherlands. For this presentation, I don't have any conflicts of interest. First of all, I would like to thank our patients with whom we are continuously building experiences and improving our care. During many patient organizations meetings, I've been inspired by families who have shared their stories about acute hospital admissions. Sebastian de Boekhorst is the father of two boys I know from our clinic, who, as an ICT specialist, has been responsible for the software development. Hanka Dekker is the director of the Dutch Patient Organization for Metabolic Diseases, with whom we have developed and hosted the website www.emergencyprotocol.net, and we will continue on this journey together. Without money, no projects. I'm very thankful to the funders and in particular UMCG for their MD PhD program. It's a pleasure to work with PhD students such as Irene Hogeveen, Fabian Peaks, and Alessandro Rossi. The last step would not have been possible without EU funding on behalf of MetAP-ERN. This is the European Reference Network, in which we closely collaborated with international metabolic centers. During several meetings in the last decade, colleagues have participated in workshops and shared their valuable experiences with regard to how they apply emergency protocols in their clinics. This slide is summarizing some additional critical moments and milestones in the development of the website. Together with Sebastian de Boekhorst in 2014, we started digitalizing our process in generating the emergency letters. We were able to translate this clinical experience into a simple algorithm which reduces the chance of making mistakes. We incorporated practical clinical experiences that we gained in the subsequent years and that we have exchanged with healthcare providers during conferences. In some of these steps, our master students and PhD students actively contributed. We learned during patient meetings and focus group meetings that this is also a topic that really matters to families. The question, how should sickness and emergency situations be managed for patients with liver GSD, was recently prioritized in the International Priority Setting Partnership in collaboration with the James Lind Alliance. The subsequent INEA project's money allowed us to disseminate the protocol to other centers and internationally. During the pandemic, as part of this MetAP-ERN eHealth project, we were able to meet the colleagues digitally to improve the emergency protocol and to launch the website. The website was introduced in June 2020, and the scientific article was published quickly thereafter. We retrospectively described the outcomes of acute hospital admissions in 128 patients representing over 470 so-called emergency protocol years. We found that in our hands, this protocol was very safe to work with. In brief, the emergency protocol describes two phases. Phase 1 can be executed by families at home when the sick dietary regimen is not well tolerated. Regular oral rehydration salt, ORS, does not contain enough calories and carbohydrates for metabolic patients. Therefore, this protocol makes use of an emergency solution that consists of maltodextrin added to an ORS solution. The amount of maltodextrin depends on the body weight. The estimated calculated carbohydrate requirements per kilogram body weight are based on experimental data derived from stabilized dose studies. The volume of the emergency solution meets the fluid requirements. Analgetics are advised for fever management to reduce energy demands. It is important that families know when to call and whom if there is no clinical improvement in phase 1. Phase 2 is executed in the emergency department or initial hospitalization, controlled by healthcare professionals, before expert metabolic support can be requested. Phase 2 occurs usually not in the metabolic center, but in a local hospital. The emergency letter lists the ideal minimal laboratory tests required to assess the metabolic status of the patients in the first critical sample. For a patient with GSD1b, these tests are blood glucose, blood gas analysis, lactate, neutrophils, and blood. In case of a patient with VLCAT, neutrophils would not be of importance, but TK and myoglobin would be added instead. Phase 2 ends with consulting the expert metabolic center and does not replace disease-specific in-hospital expert metabolic treatment. Having an emergency letter and knowing how to use it can prevent life-threatening situations and will optimize the communication between parents and different healthcare providers. The website offers the necessary information to generate an emergency letter for an individual patient. It has the goal to improve the initial care for metabolic patients during sickness at home and the first evaluation phase in the hospital to prevent metabolic emergencies before proper metabolic treatment can be started. From the main page of the website, the link leaflet contains information leaflets for families in several languages. We advise not only families and parents, but also healthcare providers who want to generate an emergency letter to carefully read this practical information and to discuss it together. Some items may be less applicable for a local situation. The page Emergency Letter allows you to generate an emergency letter. First, we carefully need to read the following information. This information is important. Each emergency letter needs to be checked by the person who generates it. After accepting these terms, one can continue to generate the emergency letter and the next page will automatically appear. After filling in the name, the date of birth, and body weight, you need to fill in the exact diagnosis. Emergency letters can also be generated in several languages. This allows to generate an emergency letter for normal situations, but also for holidays in a foreign country. It is crucial to discuss with your metabolic expert doctor, geneticist, or GSD specialist how they can be reached by local healthcare providers. This is differently organized by different hospitals in different countries. For some metabolic centers, we already included their contact details in our database. This information will automatically appear in the emergency letter. In many cases, the metabolic center is not the first hospital close to where the families live. So it should be well communicated who is the first point of contact for the families to prevent unnecessary delay. Here you can fill in these contact details. After pushing the Create Emergency Letter button, the emergency letter will be generated either as a PDF file, Word file, or HTML. Until very recently, over 1,600 emergency letters have been generated in these languages. As you can see from the next slide, most of the emergency letters have been generated for patients with MCAT deficiency and GSD1a. So where are we going to? We are undertaking several actions to disseminate this emergency protocol. We think it is important to add missing languages and disorders. For instance, some fatty acid oxidation disorders are still missing, and we find it a top priority to add idiopathic ketotic hypoglycemia to the list of disorders too. The landing pages of the website should be translated into the different European languages. On the longer term, it will be important to work on stronger consensus guidelines using, for instance, the Delphia method to find agreement on the emergency regimens. Finding a partner for sustainable production of a standalone emergency solution product is also very important. Also, we would like to develop tools to improve the communication between families, local healthcare providers, and metabolic specialists. I thank you again for your attention.